We're now going to start the physiology section of this lecture for female reproduction. Now, it's always been assumed that females' total supply of eggs was determined at birth. And just to let you know, there is some new evidence that suggests stem cells can arise from epithelial cells on the ovary surface. So this may in long term overturn previous assumptions. Now, the whole point of female physiology is what's known as oogenesis. And this is the production of female gametes that takes years to complete. So this is basically the counterpart to spermatogenesis, but this is female. It begins in fetal period with oogonia. And this is a 2N diploid ovarian stem cell that is multiplied by mitosis and stores nutrients. Now, we will get from there, once mitosis happens, the primary oocyte that will then develop into a primordial follicle that becomes surrounded by follicle cells. Remember, we talked about that. And the primary oocyte begins meiosis, but stalls in prophase 1. At birth, females presumed to have lifetime supply of primary oocytes. Now, each month after puberty starts, a few primary oocytes are activated. One from this group is selected each month to become a dominant follicle that will resume meiosis and end up on its way to become a mature ovum. Now, after division of meiosis 1 is complete, 2 haploid cells of different sizes are produced. One is called a secondary oocyte, which is a large cell with almost all of the mother cell's cytoplasm and organelle, and the other is called the first polar body. And this is a small cell, almost devoid of cytoplasm, and it will not end up being a functional ovum in the end. After puberty, the secondary oocyte arrests in metaphase 2 and then becomes an ovulated ovum. If not penetrated by a sperm, it deteriorates. But if it's penetrated by a sperm, the second oocyte completes meiosis 2, yielding a functional gamete or an ovum, and a second polar body, then again, that is not functional. So through all this division, in sperm, you would end up having 4 functional sperm at the end, right? In female, you're just going to, after all this division, get 1 functional ovum. So that can also explain why the sperm count is so high, where in females, there's a lot of energy that's devoted to just making 1 cell, and that's why we females have limited number of gametes. And so these are the events basically for oogenesis so that you can see them, right? And so essentially, if you look over here, before birth, you have that oogonium. That's the stem cell, right? And then basically, it's going to perform mitosis and make a primary oocyte that is still diploid. Now, at this point, the primary oocyte that you can see, do you see, and this is kind of lining it up so that you can see what's happening inside the cell versus what the follicle development is in the ovary. So at this point at the primary oocyte, you can see the oocyte and the follicle cells being around there, and that's the primordial follicle that's holding the primary oocyte. Now, in infancy and childhood, ovary functionally are inactive. So you can see that the primary oocyte now is arrested in prophase 1. And this is present at birth, and that these follicles are still primordial follicles. Remember, that's when the follicle cells, essentially, there's just 1 line of them around holding the oocyte. Now, early month from puberty to menopause, what happens? Well, at this point, the primary oocytes are still arrested in prophase 1. So you see here, they're still at that primary follicle stage. Now, at this point, basically, what's going to happen is that you can see over here the follicle is now becoming the secondary follicle, which is going to have essentially those granulosa cells surrounding it versus the regular follicle cells, right? And basically this is going to become what's called a vesicular follicle, which has this extra area this is also known as an antral. And basically at this point, they are making that antrum, which is that kind of fluid area to help them. And so you see at this point, we're still at the 2N stage, where we're still at a primary. Now, meiosis 1 happens at this point when luteinizing hormone surges. And so at that point, you're going to get a division. And then this side is going to be the N, but it's going to be a polar body. That's inactive. It doesn't do anything. And then you're going to get this basically secondary oocyte. And that's going to be the large cell that is mostly all the mother's cell cytoplasm and organelle. And you can see that it's really big. And at this point, there's going to be a dominant follicle that is basically going to be picked, right, for meiosis 1 to happen. So basically this guy, the secondary oocyte, is going to rest in metaphase 2. And this is only going to become the ovulated, it's going to become the ovulated ovum. And so you can see ovulation happens here at the secondary oocyte. And you can see that it's coming out of this basically follicle that's here. And so again, that other polar body goes, and these guys are going to become, they're going to degenerate. They're not useful for anything. And then you're going to have meiosis 2 completed only if a sperm penetrates the oocyte. And then you're going to get the secondary polar body that doesn't do anything, and then this ovum. Now, once this comes out, you can see it's left. The corpus luteum that's there, that's basically this ruptured follicle becomes that and essentially will degenerate, go away. So that's the stages of oogenesis. Now let's compare oogenesis to spermatogenesis a little. The number of functional gametes do different. Oogenesis produces only one viable ovum. You saw in 3 polar bodies. The polar bodies degenerate. They don't do anything. So we waste, or females waste, a lot of energy just to produce one egg, which is also the reason why women tend to be more selective when they go to copulate and when they go to actually have a child. There's unequal division will ensure oocytes have ample nutrients for 6 to 7 day journey to the uterus. It's a long move from the ovaries all the way to the uterus, right? Polar bodies degenerate and die, they're gone. Spermatogenesis produces 4 viable sperm. So in that case, they're not using a lot of energy for not a lot of yield. So they get it. Lots and lots of sperm made this way. Error rates differ. Spermatogenesis has an error rate of only 3 to 4%. So you're not going to see as many genetic abnormalities happen and or it not completing correctly. Oogenesis has an error rate of about 20%. But when you look at it, it is a lot more involved than spermatogenesis is. Now, the ovarian cycle is the monthly 28-day series of events associated with that maturation of the egg. There's 2 consecutive phases with ovulation occurring in the middle of the 2. There's what's known as the follicular phase. That's the period of vesicular follicle growth. That's day 1 through 14. And then luteal phase, which is the period that the corpus luteum is active. And that's 14 through day 28. Now, just to let you know, we do this average of 28 days, but only about 10 to 15% of women actually have this 28-day cycle. The follicular phase varies, but the luteal phase is always 14 days from ovulation to the end of the cycle. And so the follicle phase of ovulation cycle kind of looks like this, and we have the comparison up here. So let's talk about it really quick. So if you look at this follicular phase right here, we start up here with our primary follicle, right? And so the primary follicle comes from the primordial follicle. And we're going to look at this again here in a second, basically. But what happens here is that basically you have this really smooth kind of cells that surround it, and they're going to change shape, right? And basically from here, this takes about a year, and the primary follicle will then go to the secondary follicle. And so the secondary follicle is now gonna, there's more than one layer around it. So this is when the follicular cells will turn into granulosa cells here. And basically at this time, the granulosa cells and the oocytes are going to guide one another to help them basically develop. From here, the secondary follicles become the vesicular follicle. And these early vesicular follicles form when clear fluid starts to accumulate. And that's basically forming what's known here as an antrum. And this is kind of where we start their antral phase, which is completely regulated and is dependent on hormones. Primary and secondary follicles are not at all dependent on hormones. So let me write this. On hormones. At this point, basically that antrum is going to have this large cavity that forms. And this is what helps you to distinguish this vesicular follicle from other types of follicles in the past. And basically what's going to happen at this point is ovulation is going to occur. And this is when we start the luteal phase. And so you can see here that it turns into the corpus luteum. And basically, this is going to, it kind of becomes a temporary endocrine gland, because it can release hormones. Now, if there is no pregnancy within about 10 days, it starts to degenerate. And so this kind of shows you all the different stages between those. Now let's look and get just a little bit more detailed. You knew that was going to happen, right? And so here we're going to take a gander at what we were just talking about and look at it in terms. And you can find this on your book on basically 1057 if you're using the Human Anatomy and Physiology 10th edition of Mirab. This is Pearson. And so if you look at number 1 here, you'll see that is those primordial follicles. And basically, once you have those, if you look, they are going to go into step 2, which is the primary follicle, or the primordial follicle becomes a primary follicle. So essentially, and it's showing, not really showing you, it starts here at number 2. So if you look at that first picture here, you can see that around the oocyte, you have these squamous-like cells that are very flat. And then when you go to the primary, they become very much cuboidal, and that oocyte starts to enlarge. This process takes about 1 year. Now, the primary follicle then can become the secondary follicle. And you can see the secondary follicle right here. And it's included right there. And so at this point, the follicle cells are going to start multiplying, proliferating, getting more. And so they're going to form here stratified epithelial. And so this is when you go, remember, if you have one layer, it's follicular cells. But at this point, do we have one layer? No, it's stratified. There's several layers there. So at this point, this is when we're going to see the granulosa cells we were talking about. Now, the granulosa cells and the oocyte together guide one another's development, and they guide it through what's called a gap junction. Okay. And so at this point, the secondary follicle becomes a vesicular follicle. And you can tell this because you start seeing certain things forming in here. So let's look at this picture a little bit. So basically, you're going to have connective tissue, and granulosa cells are going to start condensing. And that's what forms this area right here. And this is what's called a theca folliculi. So connective tissue plus granulosa cells condense. Now, around the O site, which you can't really see, but yeah, you can, it's right there, is what's known as a zona pellucida. And this is just kind of this thick, it's a glycoprotein rich, it's kind of viscous membrane secreted by the oocyte, and it helps to encapsulate it. And so you can tell what happens here is these early vesicles starts forming this antrum. And like I told you, this is a follicle formed when clear fluid starts to accumulate. And that's how you can tell. That's an indication that it's a vesicular follicle. And so the antrum is going to continue to expand with fluid, basically isolating the ovum. And you can see that here in 4B. Now, on one side of the ovum, you have what's called a corona radiata. And basically, this is kind of sits on the stalk and one side of the follicle. Now, when the follicle is a size that's greater than about 1 inch or 2.5 centimeters, it bulges. And so that's when you'll start seeing this happen. And that's when it's ready to ovulate. Let me write this, bulge, ready to ovulate. Now, during this follicular phase, there are several of these follicular follicles that are stimulated to grow. And basically, they're triggered by follicle stimulating hormone. Now, these levels fall around middle of this follicular phase, and that's going to cause, so let me go, in the middle, you get a drop. And that's what helps decide the dominant follicle to be selected. How it truly works, they're still uncertain. And then from there, the primary oocyte of the dominant follicle completes meiosis 1 and 2 to form the secondary oocyte and the polar body. And basically, there are going to be granulosa cells in here that signal to the oocyte to stop in metaphase 2. Remember, we talked about that earlier. At this point, you're going to have ovulation. And ovulation occurs due to a rise in luteinizing hormone. Think this first part is the follicular phase, right? And think follicle stimulating hormone is going to be in here. That's going to help develop the follicle. Well, if we release the ovum, we're going to have the corpus luteum. So think the luteus phase or luteinizing hormone. It all kinds of goes together there. And so those rising levels are going to cause the ovary walls to rupture, expelling the secondary oocyte here. And you're going to see here, that's why I mentioned it, the cornea why can I not say that right now? I think it's because it's so late at night. Radiata is going to release. Now, there is this weird phenomenon that happens. It's called middle Schmerz, and this is basically the tinge of pain that happens to some women during ovulation, like they can feel it happening. I've had it before. So it's not completely unheard of. Now, about 1 to 2% of ovulation can release more than one oocyte, which if fertilized can result in fraternal twins. Now, identical twins result from fertilization of one oocyte, then separates daughter cells, right? So that can tell you the difference between having fraternal twins, right? So that's 2 ovums released, and this is 1 to 2%, right? Or identical twins is 1 ovum, right? And it ends up releasing later. So in this luteal phase, after ovulation ruptures and the follicle collapses, the antrum will fill with clotted blood. And you can see where ovulation is happening here. Now, this is known as corpus. Is known as hemorrhagicum. But this essentially will be absorbed. Now, the remaining granulosa cells and these thecal cells enlarge to become the corpus luteum. And basically, this is important because it will secrete progesterone and some estrogen. Now, if there's no pregnancy, then it disintegrates. And basically, that's what's known later as and I'm just going to write it here on the front of it, corpus albicans. And this is a scar, and this happens in about 10 days. And then this luteolytic or ischemic phase, that's about 2 or 3 days of the luteal phase, is when the endometrium actually begins to erode. And just to let you know, if pregnancy does happen, the corpus luteum begins producing hormones that help sustain pregnancy until the placenta takes over. And that's about 3 months. So it almost like it becomes a temporary endocrine cell there. That was a lot, I know. Now, how do we regulate that ovarian cycle? I did talk about a few hormones in there. So, before puberty, ovaries secrete small amounts of estrogen. And so basically that helps to inhibit the release of the gonadotropin release hormone from the hypothalamus. As puberty nears, if leptin levels are adequate, the hypothalamus becomes less estrogen sensitive, so that gonadotropin releasing hormone is released. This will stimulate the follicle stimulating hormone and luteinizing hormone that's released by the pituitary that acts on the ovaries. Do you guys realize that these are the same hormones we talked about earlier, right? So the events occur until an adult cyclic pattern is achieved. Or an menarche occurs. So let's talk about how we regulate the ovarian cycle itself. So if we're in this early or mid follicular phase, this is what's happening, guys. The hypothalamus is talking and releasing the gonadotropin releasing hormone. It travels via the portal blood to the anterior pituitary system, where it's going to release follicle stimulating hormone and luteinizing hormone. That's going to help stimulate follicles to grow, mature, and secrete sex hormones. If we go over here to the follicle stimulating hormone, what this does is it's going to help basically stimulate the granulosa cells to release estrogen. Now, on the other side, you have the luteinizing hormone over here. And they are going to prod the thecal cells. And the thecal cells are going to release androgens, which the granulosa cells are going to convert to estrogen. Now, what happens here is when estrogen is released, it's going to create a negative feedback loop. And basically what it's going to do, if you see it goes up here, and basically it's going to inhibit the release of follicle stimulating hormone and luteinizing hormone. Now, the inhibin gets released from granulosa cells, and that just inhibits follicle stimulating hormone. Now, this can stop basically all the developing follicles to basically all the, let me write it up here. At this point, when this happens, the developing follicles will start to deteriorate, except for the dominant follicle. The dominant follicle can withstand the FHS dip. Now, once we get into the late follicular and the luteinizing phase, what happens here is that you are going to get release now of the gonadotropin releasing hormone. And what this is going to do is basically estrogen levels at this point are going to continue to go up, which the mature or dominant follicle will keep releasing estrogen levels. And when they get to a critical high value, a positive feedback will happen. And so this is going to allow the gonadotropin hormone to release, and basically you're going to get a surge of luteinizing hormone. And this is going to trigger ovulation. And formation of the corpus luteum. So at this point, right, this luteinizing hormone surge is going to trigger the primary oocytes to complete meiosis 1, to become secondary. Secondary, right? And then the secondary oocytes will enter into meiosis 2 and continue on to metaphase 2 of meiosis 2. And so there's a lot of other things that happen, but we're not really going to talk about this because I feel like there's already enough going on here to basically talk about this ovarian cycle. So the rest of the things you can go and look to kind of see the other things that this luteinizing hormone does, but we're going to stop with that. We're just going to talk a little bit about the formation of the corpus luteum at this point. So shortly after ovulation happens, you have this corpus luteum that forms. Now, the luteinizing hormone stimulates the corpus luteum to secrete progesterone, and the progesterone is going to help maintain the stratum functionalis. And remember, the functionalis was the area that's inside that gets shedded whenever we or a woman ends up having her menstrual cycle, or the ovum embeds into whenever it's fertilized. And so to maintain pregnancy, if it occurs, negative feedback inhibits luteinizing hormone and FISH is released. So let me put up here. So if pregnant, right, you'll get inhibit of LH and increase of FSH. And basically, this inhibin here will enhance inhibitory effects so that the pregnancy can continue. Basically, what's going to happen is declining luteinizing hormone is going to end the luteal activity and inhibits follicle development. So basically, as this plasma progesterone continues, estrogen levels will help to inhibit. You can see that in the little line there. So if no fertilization happens, this guy goes away, right, when LH levels fall. And basically what happens is, because you're not making progesterone and estrogen, essentially the FSH and LC secretion, that blockage stops and it causes the cycle to start all over again. Oocytes are actually activated 12 months prior to ovulation, but mature 14 days into ovulation. And so that's essentially how we regulate. I told you the women were more complicated here. And so this kind of gives you an idea of what happens So, during that follicle phase, you can see they're kind of lower. Here is in the middle is ovulation, and then it goes back down again. Whew. Now let's just talk about the menstrual cycle, and it's basically the cyclic series of changes in the endometrium, and it occurs in response to the fluctuating ovarian hormones that we're talking about. And so there's 3 phases to the menstrual cycle if there's not a pregnancy, right? Days 1 through 5 are menstrual phase. Days 6 through 14 are the proliferatory or ovulatory phase. And day 15 through 28 is the secretory or post-ovulatory phases. So we're going to talk about each one of these. And so this is how thick the functional layer and the basal layer of the endometrium is. And so when we look at this, you can see day 1 through 5 right here. This is when the ovarian hormones are lowest. This is when the gonadotropin levels begin to rise. And basically, the stratum functionalis detaches from the uterine wall. See, and it says it right there. And so basically, menstrual flow of blood will last from day 3 to 5. By day 5, the ovarian follicles start to produce more estrogen. So the rise of estrogen is going to allow for this new generation of the stratum functionalis layer to basically thicken. The glands are going to start enlarging. If you can see right here, you can see that the spiral arteries are going to start increasing in number. Now, there's normally kind of this thick, sticky cervical mucus, and during this time, it's going to thin it out to help facilitate sperm movement in here. And ovulation is going to happen at the end of the proliferous phase. So secretory phase begins immediately after ovulation, and this is day 15 through 28. This is the phase that's most consistent between women. Basically, what's happening is the endometrium is preparing for an embryo to be implanted. And so during this phase, you're going to see rising progesterone levels from the corpus luteum. And that makes this functional layer here kind of start becoming a secretory mucosa. And it's going to start allowing these glands to become bigger and secrete nutrients. Basically, all of this is happening just to make, and this is the most important part of that, basically what's happening is that thickened mucus helps to form a cervical plug that blocks sperm entry. We don't need any more sperm. We don't need any pathogens or any debris. So it's going to block it all during that time. During this time, and so if fertilization doesn't occur, then instead of the corpus luteum helping with all of that, it's going to basically degrade at the end, and progesterone levels fall again, and basically this is going to allow those spiral arteries to start kinking and spasming, and then from there the endometrial cells die and the glands recess, and then they'll relax, and then the whole thing like sludges off. And the whole thing starts over again. So this is basically the 3 different main stages and what happens during them. And this is just there to help you if you want to kind of look at everything happening all at the same time to relate the fluctuations of the gonadotropin levels with the luteinizing hormone in fish between the follicular stage and the luteinizing phase, looking at how the follicle changes, and then the plasma hormone levels of progesterone and estrogen, and basically looking at how that affects the formation or what happens during the luteinizing phase, and then looking at how the different phases during menstruation are affected during these different stages. Now, extremely strenuous physical activity can delay menstruation in girls and disrupt normal menstrual cycles in adult women, or miniarchy in girls and disrupt normal menstruation cycles in women. And it can cause amenorrhea, which is a sensation or the stop of your menstruation or menstrual cycle. It can also cause a problem. Female athletes tend to have lower body fat levels, and basically adipose cells are needed to convert adrenal antigen to estrogen. Also, leptin plays a role in female puberty. It helps to inform the hypothalamus if energy stores are significant to support reproduction. If they're not, the reproductive cycle is shut down. Also, this can lead to osteoporosis. Now, estrogen is important because it promotes oogenesis and follicle growth in ovaries. It helps to increase anabolic effect on female reproductive tract, and it's there to support rapid, short-lived growth spurts of puberty. It also helps to induce secondary sexual characteristics like growing a breast, having subcutaneous fat on your hips and breast, and the widening and lengthening of the pelvis. And we looked at some secondary sexual characteristics in male as well. There's also metabolic effects. It helps to maintain low blood cholesterol levels and high HDL. Remember, those are good to help get rid of cholesterol. And it facilitates calcium uptake. Progesterone is important because it works with estrogen to help establish and regulate uterine cycles. So it helps to promote the changes in that mucus, essentially the mucus plug that we were talking about. And it also has effects on placental progesterone during pregnancy. It can inhibit the motility of the uterine and helps prepare breasts for lactation. Now, the female sexual response is limited by both psychological stimuli and touch. So anything, the clitoris, the vaginal mucosa, bulbs of vestibule, and breasts engorge with blood during the sexual response, and nipples become erect. The vestibular gland secretes the lubrication to help lubricate the vestibule. An orgasm is accompanied by muscle tension, increase in pulse rate and blood pressure, and rhythmic contractions of the uterus. Females are lucky. They have no refractory period after orgasm and can experience multiple orgasms in a single sexual experience. But orgasm is not essential for conception, where it is for males. The female libido is prompted by DHEA. It's an androgen that's produced by the adrenal cortex. And so we're going to go really quick over some STIs, and these are sexually transmitted diseases is another name, or venereal diseases. U.S. has the highest rate of infection among developed countries. Latex condoms can help prevent spread. STDs or Is are the single most important cause of reproductive disorders. You have gonorrhea. One second. It is a bacterial infection of the mucosa of reproductive and urinary tract. It's caused by Neisseria gonorrhea, and it's commonly called the clap. It's spread by contact with genital area or pharyngeal mucosa, and it's treated by antibiotics, but some strains are resistant. They're becoming more prevalent. Number of cases in the U.S. have been declining because of the availability of antibiotics. Some of the signs and symptoms for male: urethritis, painful urination, or discharge of pus. For females, the majority of females display no signs or symptoms. They might have some abdominal discomfort, vaginal discharge, or abnormal uterine bleeding. The bad thing, it can result in pelvic inflammatory disease and sterility. Syphilis is a bacterial infection transmitted sexually or congenitally. It's caused by Trichomoniasis pallidum, and it can infect fetus. Infected fetus can be stillborn or die shortly after birth if they're infected with syphilis. The bacteria invades the mucosa or even broken skin. Infection is asymptomatic, which means you have no symptoms for 2 to 3 weeks, and then painless chances appear on the site of infection, but they can disappear within a few days. If untreated, secondary signs appear several weeks later. So these are kind of like pink skin rash, fever, and joint pain can develop. It usually appears between 3 to 12 weeks, then disappear. The disease can have a latent period, which may or may not progress to what's known as tertiary. Syphilis. It's characterized by gumas, which are lesions that develop in the central nervous system, blood vessels, bones, and skin. It's very much treatable through use of penicillin, but the number of cases have been increasing. The most common bacterial STI in the United States is chlamydia. It is caused by Chlamydia tracheomatis. It can be contracted from birth canals by newborns. It's responsible for about 25 to 50% of all diagnosed cases of pelvic inflammatory disease or PID. Symptoms are urethritis, penile and vaginal discharge, abdominal, rectal, or testicle pain, painful intercourse, and irregular menses. 80% of women have no symptoms, though. Left untreated, it can lead to sterility. Now, this can also cause arthritis and urinary tract infections in men. Like I said, newborns can pick it up from the birth canal, and they can develop what's known as Trichomoniasis. And this is a painful eye infection. It can lead to corneal scarring. You can also get respiratory tract inflammation, including pneumonia from this. And the treatment is tetracycline. Trichomoniasis is the most common curable STI in active young women in the U.S. About 7.4 million new cases are diagnosed each year. It's a protozoan infection, so it's really easy and inexpensive to treat. Symptoms are yellow-green vaginal discharge with a really strong odor. However, some patients can be symptomless. And genital warts is caused by the human papillomavirus, HPV. It's a kind of a string of herpes virus. It's the second most common STD in the United States. About 6.2 million new cases each year are actually diagnosed. Realize because so many people are asymptomatic that a lot of people go undiagnosed. 80% of cases of invasive cervical cancer are linked to some strain of HPV. Most strains do not cause cancer. It's only a couple of them. One, it's like 16 and 18. One causes genital warts. One causes cervical cancer. And there's a couple more. I just can't think of them off the top of my head. Treatment, difficult and controversial. Some physicians prefer to leave the warts alone. Some prefer to do basically laser surgery or freeze them off, cryosurgery, or alpha interferon treatment. The cryosurgery and laser can be painful from what I hear. Genital herpes is caused by herpes simplex virus 2. Possibly 1/4 to half of American adults carry this virus. Only 15% display signs of infection. It's characterized by latent periods and flare up with vesicle formation. They can be passed to the venous, and basically congenital herpes can cause malformations. They can be treated with acyclovir and other antiviral drugs. And so the last part of this is talking about genetic sex and embryological and fetal events that happen. And so we, if you remember, have 46 chromosomes in fertilized eggs. 2 are sex chromosomes. The other 44 are autosomes. So you have the final sex chromosome. It can be the X chromosome is large and the Y is quite small. So in females, it's XX. Each ovum always has an X chromosome, and for males, they're XY. So 50% of the sperm contains X chromosomes and 50% contain Y. Now, this determines the genetics of sex. So basically what it's saying is if you get an X from the egg and X from the sperm, you're going to be a female. If you get an X from your egg and a Y from the sperm, you're going to be male. And this SRY gene is a master switch on the Y chromosome that will initiate testes development and maleness. So the father determines the sex of the child. And in history, where all these women were decapitated because they could not produce a male heir, it was actually the king's fault. So there are some homeostatic imbalances that happen to this. It's called non-disjunction. And this is when, during gamete formation, that the meiosis doesn't happen correctly. There's actually 2 types. Non-disjunction type 1, which means during the first stage of meiosis, it doesn't separate outright. Non-disjunction type 2 is during the second stage. Non-disjunction type 1 actually makes it so that the majority of all the gametes are messed up, where in non-disjunction type 2, only 2 of them are. And it can lead to different syndromes. So most of the time during non-disjunction, it's going to lead to spontaneous abortions. But there are times where those actually survive. Turner syndrome, for instance, is female. And so in this case, they only get one single X chromosome. You need an X chromosome to survive. You do not need a Y to survive. And basically in females, whenever you have the XX, one of them is going to be inactivated. And that should make sense because in males, they only have one. Now, in some species, they end up basically, some will become inactive, others won't. And you can see that happening in something like a calico kitty cat. It's like the black ends up having one X that's activated and the orange part is the other one. So you can see where it's different. We don't have anything really like this. But in Turner syndrome, what happens is you only have one X, you don't have the other. So because of this, they won't ever end up developing ovaries later, so they will become sterile. So, females with 4 or more X chromosomes are intellectually disabled and have underdeveloped ovaries with limited fertility. Klinefelter's is male. And so basically, this is when it's XXY. They're sterile and are normal or only slightly below normal intelligence. And a lot of times with them, you can tell males tend to have more like kind of feminine characteristics, as in their face is a little bit, instead of it being so rigid, it's a little bit more smooth. Their hips tend to be a little bit wider apart, kind of look more like hippie instead of being straight down forward. And so that's what they look like. And so basically during the development of the reproductive system, sexual differentiation of the reproductive system includes basically there's sexual in different stages where the embryo could develop into male or female. And so you have these paramesophrenic ducts, basically future female ducts, form lateral to mesophrenic ducts for future males. So basically, there's going to be a point where the decision is made. And so Mullerian ducts are basically the areas that are going to be basically female. and Wolffian ducts are going to be males. And the gonads begin developing in week 5 as gonadal ridges form. Basically, the primordial germ cells will start migrating to the gonadal ridges to provide germ cell destined to become spermatogonia or oogonia, right? Testing formation begins in about week 7 for male, and female ovaries start to develop in week 8. And so if you have the SRY gene about week 5 to 6, here, there's indifferent, right? So you look here, you'll notice the Mullerian. This is future female ducts. The Wolffian, this is future male ducts. They're both there, right? Nothing looks different. Whether you have, now this is going to be what ends up being the male, and this is what's going to end up being the female, right? So about week 7 to 8 for males, you'll notice here that these particular ducts are starting to degenerate. And these are forming the vas deferens, where in females, these are starting to degenerate, and these are making the uterine tubes. So this is a differentiation that happens due to the presence of that SRY gene. And you can see the locations are different. For instance, the urinary bladder in males in the middle, it's starting to move over to the side of the side of where the uterus is starting to form with that mesonephric duct. All right. Now at birth, the difference between, you can see here, hugely different between the development of the two forms, right? So basically, the sexual differentiation, external genitalia start to form in about week 8. And so the genital tubercle becomes the penis of the male or the clitoris in the female. The urethral fold will become the spongy urethra of the male or the labia minora in the female. And the libido-scrotal swelling will become the scrotum in the male or the labia majora of the female. And so when we're talking about this one is like the counterpart to this one, it kind of explains it. If testosterone is absent, all embryos develop into females because that gene helps to increase the level of testosterone. And so basically this just kind of shows you the development of the homologous structure of the external genitalia in both sexes. And you can see up to about week 5, they're the same, you can't tell. And then the activation of testosterone will happen. And then you can see basically the glans penis forms. And you can look over here and see all the different things that we've just talked about located in those different pictures. I'm going to spend a lot of time on that. So there are homeostatic imbalances for this, pseudohermaphroditism, individuals with external genitalia that don't match their gonads, right? It's caused by interference in normal sex hormones produced in embryo. So embryonic testes do not produce testosterone. A genetic male develops female accessory structures and external genitalia. If a genetic female is exposed to testosterone, The embryo has ovaries, but develops male ducts, glands, as well as a penis and an empty scrotum. And this is why many seek sex change operations to match outer self, the external genitalia, to their inner self or their gonads. At about 2 months before birth, testosterone will stimulate the migration of testes towards the scrotum. Migration is mechanically guided by fibrous cords called gubernaculum from each testes to scrotum. Ovaries also descend but stop by those broad ligaments. Cryptorchidism is the failure of testes to make normal descent. It can cause sterility, increased risk of testicular cancer. Surgery can be performed. And basically, and we're almost to the end, guys, during puberty, like we talked, fish and luteinizing hormones are elevated at birth but drop and remain low during prepubescent years. Puberty is basically the period when the reproductive organs grow to adult size and become functional. And it occurs in response to rising levels of gonadal hormones, the follicle-stimulating hormones and the luteinizing hormones. Secondary sexual characteristics will appear during this time. This is the earliest time that reproduction is possible. And menopause for women is when menses has ceased for an entire year. It's equivalent to no menopause. There's no equivalent to menopause in men. And basically, there's a declining estrogen levels, and it can have a full body effect. It causes atrophy of reproductive organs in breast. It'll cause irritability and depression in some, hot flashes. And this is because as the skin blood vessels undergoes intense vasodilation, it can feel like it's really hot. Gradual thinning of skin and bone loss, and increased total blood cholesterol levels, and falling HDL, so it can cause problems with cholesterol. And we are finished. Yay! Have a good day.